Welcome, and thank you guys for coming. I know it's oftentimes these are very early in the morning, and so the attendance is greatly appreciated. So I want to just kind of briefly go through what we're going to be doing here this morning and introduce our panel, but give you just a little background as to the nature of this breakfast discussion, because it's a little different than some of the discussions you may be used to. So we all know that in 2014, the FDA issued a safety communication regarding power morcellation at hysterectomy or myomectomy for fibroids. So they warned at that time that undiagnosed cancers, specifically perhaps sarcomas, may be spread with morcellation. The FDA discouraged the use of laparoscopic morcellation for hysterectomy and myomectomy for uterine fibroids. So the FDA then, they went on to hold a public hearing in July of 2014, and that was followed up with some guidance that was issued in November, including a very specific warning and black box warning that uterine tissue may contain an unsuspected cancer, and that the use of laparoscopic power morcellators during fibroid surgery may spread this cancer and decrease the long-term survival of the patients. And the other important piece of this black box warning was that this information needed to be shared with the patients when considering surgery that's using these devices. So needless to say, with kind of that very quick introduction, that this was a very trying year for us in minimally invasive gynecology. And the FDA guidance really affected the way we've practiced ever since. During this time, and between that time and even now, many institutions kind of developed their own different guidelines for the use of power morcellators. Some delineated very carefully the limitations on using the power morcellators, some banned it altogether, and then others actually ignored it. But by ignoring it, they actually took the morcellators off the shelf, which effectively was a ban if the devices are not available. So with these changes to the way we practice, power morcellations have certainly been reduced. Now, the other side of that is it's led to more laparotomies, longer hospital stays, and definitely it's led to costlier care. Now, a very important recommendation that came out of this FDA public hearing was the need for safety improvements and mitigation strategies. Olympus has really risen to the challenge here by introducing the pneumoliner containment and tissue extraction system, which is the first FDA-cleared containment system for power morcellation. So this morning we have 4 experienced and very distinguished minimally invasive surgeons that are leaders in our specialty, and this is going to be a little bit different format than you may be used to, because we like this to be an interactive discussion. And really, the focus is to talk about, discuss, and try and arm you with information that can help you advocate for your patients to influence your hospital policy regarding contained tissue extraction. And I think it goes beyond just contained tissue extraction. One of the things that's I would say one of the strengths of our specialty and being a physician in general is advocating for our patients and making sure that we have the ability to practice the best medicine that we can for our patients as we see fit, and in collaboration with our patients. And so that's one of the more important things that I think that we need to keep in mind, and sometimes gets lost as we become more employed physicians or in certain institutions where we may feel like we've lost our voice a little bit. So hopefully we can help with that. So let me introduce our panelists. Dr. Barber received his medical degree from the University of Virginia. He did his residency in internal medicine and OB/GYN at Duke. He then went on to complete a fellowship in GYN oncology at the University of Alabama. He joined the Lombardi Cancer Center at Georgetown University, spent 16 years rising to the rank of professor. He is currently a clinical professor at George Washington University and the director of gynecologic oncology research at Holy Cross Hospital. So Dr. Barber is actually known for his expertise in robotic surgery in both benign gynecology and GYN oncology. And he's one of the top 15 users worldwide for these indications. Dr. Yonker attended medical school at the University of North Texas Health Science Center after going to TCU, where I went. So she completed her residency in OB/GYN at the University of Oklahoma and her fellowship in MIGS and pelvic pain at the University of North Carolina. She at that time also completed her master's degree in clinical research. She then went on to join Vanderbilt in 2013 as the program director for the Fellowship of Minimally Invasive Gynecologic Surgery and is currently an associate professor. She's on the board of the Fellowship of MIGS, has numerous publications, serves as a reviewer for many of our prestigious journals, including the Journal of Minimally Invasive Gynecology and the Green Journal. Dr. Coe graduated from Tulane Medical School, did a residency at the Mayo Clinic in Rochester. She then entered private practice, but then quickly returned back to Mayo, this time in Arizona, received her fellowship training in female pelvic medicine, reconstructive surgery, and urogynecology. She went ahead and stayed on and directed the urogynecology and MIGS fellowship programs at Mayo in Arizona. In 2015, she joined the Cleveland Clinic, where she's currently the director of benign gynecology. So Dr. Coe, as we all know, is published in the field, having authored many peer-reviewed articles and book chapters, and serves as the senior editor for the Journal of Minimally Invasive Gynecology. She also served as the president of the Fellowship Board of MIGS in 2015. So Dr. Brown attended the University of Cincinnati Medical School and then completed her residency in OBGYN at the University of Maryland. She completed her fellowship in GYN oncology at the University of Texas MD Anderson Cancer Center, and she held a faculty position there for 17 years, becoming a tenured professor. She is currently the professor and associate director of gynecologic oncology at the Levine Cancer Institute, Carolinas Healthcare System, and is clinical professor of gynecologic oncology at UNC. She is active in the AAGL, AAGL, to name numerous other societies and cancer boards. She has many publications also as a journal reviewer, as well as a board examiner. She's an active lecturer both nationally and internationally. She actually participated in the FDA public hearing regarding morcellation, and she was the spokesperson for the AAGL and authored the AAGL's position statement to the FDA on power morcellation. She's also served on the AAGL Board of Trustees in 2012 to 2014, as well as the MIGS Fellowship Board, and then now, of course, as many of you may know, she's been elected to serve as the treasurer for the AAGL. So big congrats to Dr. Brown for that. So,
Thank you.
So just to run through the morning here, want to go through meet the panel, of course. We want to talk a little bit about the history and experience with the institutional bans. There's a reason we're sitting in chairs up here is because we want this to be conversational. Then we want to talk a little bit about the changes and methods and reasons to change the way we do things, and some of both risk reduction strategies that we can employ both clinically and from a legal risk, and the tools that we might use along those lines to make these resources available to our patient. And again, to at the end of all of the discussions, be able to advocate to our patients to do what I think many of us believe is to give them the safest minimally invasive surgery that we can. Here's our standard disclaimer. Essentially says that Dr. Brown, Dr. Yunker, Dr. Barter, Dr. Coe, and myself are all paid educational consultants to Olympus, and that this is for your general knowledge, and any medical procedures that are performed have to be on label and to the standard of care. So contained tissue extraction has some warnings and some contraindications, and hopefully you guys can read that. But basically it says the top line is really going to be the most important here, where it says that the information regarding the risks of the procedures and devices should be shared with our patients. So it's important our patients know and understand what we're doing here. And again, what we talked about when I initially presented this, that uterine tissue may contain an unsuspected malignancy, and the use of power morcellation during fibroid surgery can spread cancers. The PK morcellator has similar warnings, so that the device warnings line up for both the containment and the morcellation. And we need to be sensitive to these labeling changes in the FDA guidance as we continue to counsel our patients. It's very important that we follow this guidance that they've laid out. So again, quick introduction so that we can be armed for the discussion, and then we can move on to a bit more of the discussion. So the Pneumaliner contained tissue extraction system is the first FDA-cleared system for contained power morcellation for benign gynecologic tissue. And what it basically is, and there's the diagram here, is an introducer with a containment bag. The bag is then introduced in through a port that is a multiple access port. The bag is deployed, opened, the tissue to be resected is placed within the bag, and then the bag is inflated, recreating the laparoscopic environment now inside of a containment, and then morcellation occurs, and then residual fragments and debris are able to be removed within an intact bag. So it's a single opening, single access, single point of ingress and egress, which should provide complete containment. So we want to talk just a little bit about the history with institutional bans for the panel. So we'll start with Dr. Brown here. And, I want to throw just a quick couple of questions by you guys, and I know that you guys can see some of those questions on the confidence monitor with help, but basically what we want to know is that we all have different practices, and I'd like for you to describe your current practice environment. Are you in an institution or a health system or in a community practice like myself? Has your hospital restricted or banned power morcellation? Pretty much what were you doing before and now after any of those changes that were made in your hospital? And do you still have this restriction or ban? And who, and this is a really important question for all of you, so who or what group was instrumental in determining what the status of power morcellation would be in your institution? And how did that impact you, and how did you go about it? Was it a key person or a key committee?
So, yeah, I'll share actually my experiences with you that actually span a couple of hospital systems now. So I'm a gynecologic oncologist. As you heard, I was at MD Anderson for 17 years. It's a big cancer center in Houston. Currently, I'm at Levine Cancer Institute in Carolina's healthcare system. So those are two really very different systems. And I'll share with you kind of my experience in both places. So at MD Anderson, it's a cancer center. So they actually never stocked power morcellators. So they did not institute a ban. They simply didn't have the equipment to perform such procedures. However, when I was in Houston, I also practiced at the Women's Hospital of Texas, which was sort of your privatedemics model. So a large number of private practice physicians that supported residents from several programs across the city, very clinically busy, and they did institute a ban on power morcellation shortly after this controversy in 2014. Now I'm at Carolina's healthcare system. It's a very large healthcare system, level 1 trauma center, very busy OR. My understanding of what happened before I got there was that it went from no ban, just pulling the equipment, and I think that was sort of a common practice across the country at that time. So almost a subtle ban, because you certainly can't do the procedure if you don't have the equipment, to a formal ban on power morcellation. And we're dealing with that now, 3 years later. And in terms of who's the champion, that's me. So as an oncologist, really the safety of our patients is paramount. And I really believe that this system with tissue containment is absolutely the way forward. So when I work with the hospital administration, I'm not just saying words. I really truly believe this. I've published on it. I think it's the right thing to do for our patients. And so that kind of arms me with the information to talk about this. I think sort of in the process of doing this, it's important to get the people behind you before you go to your board. And so that may take a little more time than just showing up and saying, hey, I've got this new tool that I want to use. This is a very emotionally charged, media charged, legally charged issue. And so in our experience, it's been important to get the oncologists on board. So there are 5 of us, and we all need to share the data together as a group. The urogynecologists, the minimally invasive gynecologists, and then general OBGYNs. Everybody needs to be kind of on board with this. And in our system, really some of the power players are the nursing staff. And if they're understanding the benefits of this, they're going to be behind you as well. So I think that's sort of where we are in our process.
Dr. Barter?
Yes, I sort of similar situation. I'm a GYN oncologist, and our hospital basically in April of 2014, when the first warning came out, I was surprised, I think like all of us, because, classically we got trained at one at 1,000 was the risk, and we thought, well, gosh, that's seems to be pretty small. But when the FDA came out and raised the issue of maybe that's not the number, my feeling, frankly, was we need to stop and figure out what we're doing before we do it. So there was a committee of people that used morcellators, and I must say I was the only one that said we need to ban this till we can figure this out. And it didn't matter what I felt or what anybody on the committee felt because we're in a hospital chain, and the next week they just took it off the shelves, so it was gone. And I've had sort of I feel that there is, we're jaded. We very much dislike cancer, and so anything that even hints of harming a patient or doing anything untoward is sort of not in our DNA. And so, but I felt very strongly that I knew back then that industry would figure this out. It's reasonable, it's a good instrument, it's a good tool, it's a good concept to not have to open everybody up. But I think it's very important that we try to assess this as we go along. So I've had this huge odyssey in the last 14 months. I started a year ago, August, and I went up to Olympus and got trained on the pneumoliner. And then the battle began because I got all kinds of pushback from every corner about using this. And I think you just can't get emotional about it. You have to believe in it, as I do, and I firmly believe that we need to invest. We need to use this and see if we like it, see what the combined numbers are. Make sure that we're still doing the best thing for our patients. And so I often feel I'm Sisyphus, the guy that had to roll the rock up the hill and it would come back down and hit him, and then he'd go back, and that was me for the last 14 months. So I approached it from that standpoint, and I went through our national people and just struggled with that. I put on I showed them some slides and presented to their big group, and so finally, and then they got it to the national lawyers for our health group, our hospital chain, and the lawyers kind of said, "It's FDA approved. It sounds like you should be able to use it." Because what I had to do, I had to get it through as a research study, and my intent is to report. Obviously, we need to get these numbers together quickly and see what the numbers are. And so I got this through the IRB at our hospital, and I do a lot of different chemotherapy studies, so I'm very familiar with the IRB, and so that was sort of, I got licensed to use this device November 1st. But you just have to keep plugging away. It's not emotional. It's believe in the science and do the right thing.
And Dr. Younger, how about at Vanderbilt?
So we had when the ban went forth in 2014 at our institution, we had the instrument that was effectively pulled from the market. That's the one that we had. So we had an indirect ban, as Jubilee kind of talked about it, because the one that we had was the one that was taken away, and so our institution was a little bit slow in allowing us to try out some different ones. And so we decided to be proactive from the get-go on that and created a document in our own department that wasn't asked of us, that we were really the writers of and the originators of, and that document essentially laid out our feelings about the controversy, acknowledging the concern. We highlighted a lot of literature that supports minimally invasive surgery as of course, the least risky option for surgery. And then we also laid out a plan for still safeguarding the safety of our patients. And then we put that up, and then that was very well received by the institution. And then slowly we began kind of trialing other types of morcellators, and now we have the containment system, and we've had no issue with having that in our hospital.
What about you, Dr. Coe?
So, thank you. Thank you for having me here. What I'd like to highlight from all of this discussion is that the issue is with morcellation, with whatever means it is that you do to extract your tissue. So at the Mayo Clinic, when the ban came on, that as an institution for many years, we have been really careful about our selection of patients for tissue morcellation, whether or not we approach the extraction of the tissue vaginally with laparoscopy, robotics, contained or not contained. So when the ban came on in 2014, it did not necessarily change our practice because we continued with the selection criteria that we did. We just did not have the tissue, the power morcellator available to us any longer. When I went to the Cleveland Clinic, the ban was in place at that point. I have to say that I'm very fortunate to be engaged with a group of strong minimally invasive surgeons, both in the GYN oncology section, the urogynecologists, and also the benign gynecologic department. So from there, when I came into the Cleveland Clinic, I engaged the radiologists and just brought in the much more of an awareness of the role of imaging, and I know about the limitations of imaging, but just to make the entire community aware that the screening is extremely important in this issue. So I engaged the radiologists. I initiated what we call a benign tumor board to bring up these difficult cases, complex cases, bringing in all of the different departments and talked about these cases and how we would approach these large fibroids or complex pathology in benign conditions. So I would say that with that awareness and also being armed with the literature, the level of evidence that we have regarding this issue, we temporarily lifted the ban at the Cleveland Clinic. We brought in a group of 9 champion minimally invasive surgeons who were then trained with a containment system with the pneumo liner, and now we are using it.
Thank you. And I'll speak a little bit to that from the community hospital standard. And what we did was very similarly, I mean, you can see that there's a clinical component that we're all using as our foundation. And then we're using that to go ahead and approach the system, if you would, whether that's an academic center. In my case, it was a community hospital center. And the way we did it in my system was very similar. We started with our minimally invasive committee, and we, in a community hospital setting, said, we have guidance, and our guidance comes from AAGL and ACOG and the SGO, and they're setting a standard, and they've listed some requirements. The FDA and recommendations. The FDA has given us their guidance on this and their rules and regulations regarding this. And so we have a roadmap to follow here, and now we have an FDA-cleared product, and we believe that this is in the best interest of our patients. So the minimally invasive committee took this on. And then in our case, excuse me, that went to our general overall surgical committee. And that's the approach that we were able to take. And then we in a community hospital, we lean on our academic partners because we know that they're doing the academic exercises that are going to give us in a community hospital the confidence that we need to move forward. So that's what's happening in my world too. And basically my question to all of you is, so what have you been doing in regard to your surgical approach to tissue extraction? And for you, have you been using contained extraction for your laparoscopy cases? And are you doing it by hand, or are you doing it with power morcellation? And what are you seeing as the pros and cons within your own environments? And then we can weigh in on this as well, but I'll have Dr. Yunker here talk a little bit about what you guys have been doing. And then please feel free to come to the microphone and participate.
We were free to explore the option in 2014 of other morcellators, but that wasn't going to be fast, if you know, an academic institution. So we became really good at other methods of getting getting large things out of small holes. And so we really perfected our art of vaginal morcellation and then the in-bag morcellation with the X-site technique. And we got pretty good with that. Of course, there are still certain patient populations where that is extremely frustrating still, and certain sizes of uteri as well. You know, it's not ideal, but, you know, when you have to improvise, you improvise.
So Dr. Barter, what have you been doing?
What we've been doing is, for instance, with a fibroid uterus, we would put it in a bag and then either manually morcellate it transvaginally or make a small incision and morcellate it with Leahy clamps and a knife. And the thing that I think what we're going to start doing after talking to Tony about this was that I'm going to take the bag now because I feel, you know, like when there's never any doubt the surgeon's never at fault, right? I mean, we all know that. But what I want to start doing, though, is when we bring the bag out, now I want to take the bag and fill it with water and at least see that we're not injuring the bag. Frankly, I don't think that we've ever ruptured a bag. I mean, I know we've never ruptured one. Whether they're micro leaks or something, I haven't proven that. And so I think that's I think the idea is that as we go along in this endeavor, we need to prove it to ourselves and on a national level as well that we're doing good things and better things.
And I think you know, the membership here and our academic partners in Dr. Cohen's group, Dr. Einerson's group, they're looking in that direction and have published studies now and again presented yesterday as well, looking exactly at that. And what is the rupture rate? What is the leak rate for both, you know, vaginal, abdominal, laparoscopic? What are the leak rates? So as we move into the arena of containment, it's great, and that's something that we feel like we should be doing. But we need to do the other part of that, is to test it and refine exactly and continually improve these techniques as we move forward too. So, question from the audience here, commentary.
Throughout this whole process and talking about this situation, we decided to not discontinue power morcellation. We felt that there was, even though the FDA had come up with their initial recommendations and there were bans across the city, we decided that evidence-based medicine at that time would not rule that out. However, we did have the power morcellator removed from our hospital bag because of J&J, and we ended up with 2 morcellators that we had in our institution that continue to be used there. We also instituted using the intra-bag morcellation by hand, several bags, and we've used that as well as vaginal morcellation contained. We have used all of this, but using also a informed consent that we came up with at that time. Up till now, we have continued to morcellate laparoscopically in what we consider the low-risk patients, and so far have had no problems with that. We are not doing large uteri using this method for obvious reasons, because it's much more difficult. And we have noticed an increase in laparotomy because a lot of our doctors are still afraid to use power morcellation to return to that. We used a lot of Dr. Brown's data, also Kim Coe and Debbie Richardson article to back our institution. And we have also used data from other institutions.
2 presentations that I've been aware of so far that have talked about preoperative screening. And you know, there's several different algorithms that different institutions have followed. There was a large study in France, and then the Hopkins data that I've seen, and really no missed sarcomas with that. And so I think that we're coming from in just a short period of 3 years where we had very few data going into this in terms of preoperative evaluation, to a point now where 3 years later we're really gathering pretty good data on how to screen our patients before surgery to really mitigate risk.
But just changing the subject a little bit in regards to what the patients want. At Mayo, I had one of our fellows do a survey of our patients around 2015 in regards to their the patient's thoughts about power morcellation and the risk of leiomyosarcoma. And what we heard from our patient base is that they still want to discuss power morcellation, and some of them take the risk of about 1 in 500 to 1 in 5,000 as a reasonable risk for accepting of that technique. Given that what we've been doing is that we've been using a site technique doing all bag contained hand morcellation, and what we find is that it is a tiring technique. Up to about 1,000 grams, we do pretty well. We do most of those vaginally. Above 1,000 grams, we do most of those making the incision slightly wider, say about 4 to 5 centimeters on the abdomen, and doing hand morcellation that way.
What are you doing to kind of, with contained power morcellation or morcellation in general, to reduce the risks in terms of both clinically and legally? And we'll just kind of maybe summarize that a little bit and start with you.
Right. So I think what the community has done, and I'm really very proud of the things that we have done since the FDA ban, is to come together as a community and re-look at our evidence, right? The very nice study that I bring up with me, and also with my discussion with the hospital administrators, is the meta-analysis that was done by Pritz et al., showing that the risk for a sarcoma in patients who present with fibroid is actually much, much less than what the FDA had reported, given the number of studies that they included, the correct studies that they included in this. And that's the level of evidence that we bring in. So I think arming yourself with the studies, what the impact of the ban has done to our women, our patients as a whole, increasing the number of laparotomies and then affecting, increasing the complications as a result of the number of laparotomies that are performed. These are the things that your hospital administrators need to know.
Yeah, so I mentioned the document that we put forth to our administration, just summarizing morcellation and making our case. And when we talk about patient selection, it really was three main things. One was appropriate patient selection, so not your postmenopausal patients, not your concerning looking leiomyoma on MRI. And the second tenet is adequate preoperative screening, and then the third tenet is consent, which we've talked about. So as far as adequate preoperative screening, we're very, you've got to be up to date with ASDCP guidelines. Those Pap smears have got to be current. You wouldn't take anybody to the operating room without that, regardless of the patient. Appropriate endometrial sampling, certainly if they're having any changes in their bleeding patterns. And that needs to be, not something from 5 years ago, but something within 6 months of the surgery. Imaging, whether that needs to be ultrasound or MRI, as Dr. Koh mentioned. And then, if you want to add in the LDH isoenzymes, a good exam, and definitely a family history. We sometimes skip over that, but trying to pick out if there's a concern for a hereditary cancer syndrome in there. So all of these preoperative screening tools have, helped us really narrow down the population that's appropriate for morcellation, whether it be power morcellation or in-bag morcellation by hand.
So along with our patients, one of the other things we do is we want to have our goals and our patients' goals aligned. So we're sharing our professional guidelines, our AAGL guidelines, our ACOG guidelines. We share those with our patients as well, and that, again, can help you reduce risks, both, again, the clinical likelihood. If the patients are informed, then they know what's going on, and then, of course, the legal risk for both you and your hospital. Dr. Barter, what are you seeing along these lines?
It's interesting. Again, I'm beginning to do this as part of a protocol, and we actually have a 9-page consent that we have the patients look at and sign, and that's fine. But more importantly, I want them to understand that we're not omniscient, and that I can't, even though the LDH, the MRI, your age, or whatever, we just don't know until we get it out. And obviously the goal is we very much have to stay within the FDA guidelines. That's very clear in that one slide that Tony showed. I mean, you got to memorize that, because we can't waste this opportunity.
So we want to have that strong adherence to our existing and current warnings, and we want to have a good, strong clinical preoperative evaluation. We want a very strong informed consent. And Dr. Brown, what have you?
I would say all of those things, and also documentation. So I make absolutely certain that in my note I document ad nauseum what I've discussed with the patient. And yes, that's protective, but honestly, it's really reflective. I have long conversations with every single patient who I think I might even consider morcellating the mass, even to extract it vaginally. So I really do document and discuss all of that. I think the other thing that just comes to mind is that, this whole containment strategy is relatively new. All of the data that we had back in 2014 was sort of scattered, and it was pre-containment. So I think, in terms of just risk reduction, what I hope that we'll see as we gather the data from this trial is that our risk is that patients are exposed to is incredibly less with all the things that we're implementing, but most importantly with containment strategies.
Just briefly about too is that there's also product training. So one of the things that also helps our patients be safe is that we're effectively using the products that we have. And so just pulling devices off the shelf and saying, I'm a qualified surgeon, so I'm going to use this orthopedic device for this procedure isn't appropriate. And so I think the FDA is directing us by requiring training for the CTE. And so I think having formal specialized training also becomes a tool in this process that not only can help us do better surgery for our patients, but also get our hospitals and systems on board. So with the kind of the world that we live in, with evidence-based medicine and patient guidelines and patient consent, we want what do you individually, in one word answers, what do you think was the most and convincing tool that you were able to utilize within your institution to get them to bend to your will, Dr. Coe?
I'm smiling. I really have the gift of working with Tommaso Falcone. First and foremost, a strong proponent, a strong a partner who is very aware of the level of evidence, a strong MIS surgeon who's not just the chair but also very much involved in the institution. There was something else I wanted to mention, but I'll go on to Mandy.
I would say ours is actually kind of similar, and ours was numbers. We came together as a group and as a department. We were all on the same page, and that was extremely helpful. And our voice then, of course, was louder because we were all together.
Persistence, grace, alacrity. You have to understand it. You have to. These people or administrators approach it. All they're concerned about is money, and they don't want to get sued. And you have to understand that you have to present it from their standpoint. You can't be facetious with these people. You just have to be very matter of fact, present the data, present the problems. I know I sent them, I had a patient that we got sent to that would have been a perfect candidate. And, we had to make a mini laparotomy, which we wouldn't have. And she stayed for a day or two. And I wrote them all. And I said, gosh, here's this nice lady. And, I could have sent her home that day, but she stayed 2 days. So, look at it from their side and be humble and persuasive.
Dr. Brown, any commentary?
I would say, and I'm still in the thick of this actually, is communication and value. So I think that exactly what you're saying, communication with the people who aren't as familiar with these data as we are. It's our obligation to communicate with them effectively and share those data. And secondly, really what you're talking about is value, is helping the administrators, the OR committee, understand that we are improving quality by enhancing patient outcomes and decreasing costs as we do it, because we're keeping people out of the hospital by the ability to do this.
If I may just add, Tony, Be the champion. Be the champion of your patients. I'm thinking that without Tomas Falcone by my side, I would have to bring that forth. And if you do it methodically, do it systematically, instead of, I speak for the entire Cleveland Clinic system, right, that with over hundreds of OBGYN surgeons, we did not just uniformly lift the ban. We chose a small group, 2 handfuls of champion surgeons who would then take this new system on and trial it, evaluate it, come together after an adequate period of time, and then reassess whether or not it should be uniformly lifted.
Great, thank you. So one of the things that we want to talk about is we're focused on the clinical avenues of how we take care of our patients. We don't always understand what's involved from the infrastructural standpoint of our hospital or our systems. And so I wanted to take a second because we may not know how that equipment gets on the shelf in your operating room. And so that's part of being able to advocate for your patients, is not only to go through your clinical committees, but to figure out the right departments, if you would, within your hospital. So maybe we'll take a second here as we are getting near the end and educate you guys as to what does it take? Who's involved in this? Which organizations? Well, it actually comes down to, and sometimes they have different names in different institutions, but there's a quality and risk management group. There's a value analysis committees, oftentimes within the hospitals. There's our administrations and our high-level administrators who maybe your hospital actually has to go through a system to get that into their hospital. And we have our legal concerns through our legal department, and then the boots on the ground, the materials management people. So maybe if we could just take a second and kind of describe to you a little bit about our understanding of those groups. So Dr. Juncker, why don't you talk about maybe the quality and risk management piece?
So if you're going to approach quality and risk management to make your argument for more sedation, whether it be power impact, you have a lot of literature to take with you to support your argument. And it's every day we're getting more and more literature to support this practice. And some of the best articles, there's one by Dr. Seedoff that is a decision analysis, which looked at risk of death from leiomyosarcoma versus those who might be converted to laparotomy with a ban on morcelator. And it showed that patients were, by and large, much more likely to die of infection or thromboembolism causes related to surgeries that could have been done minimally invasively had a morcelator been available, as opposed to a risk of dying from leiomyosarcoma. So that's a great article. And there's also another post-morcellation ban analysis that looked at what was the risk in hysterectomy patients. I believe it's out of Michigan, but don't quote me. And it did show that it's out of Michigan thing. And it did show that there was a significant increase in the risk of infections, and here's going to be your key argument, readmission rates, because these are quality metrics that now are reportable and are measured across the United States. And so I think that you can easily take that argument to your quality and risk management to support your cause.
So, Dr. Coe, you already talked a little bit about approaching the hospital's administrations and how you maneuver. Any last-minute thoughts on looking at the hospital administration?
So just to very briefly describe the process that we went through it concurrently. One side was just starting the conversation within my division, and I represent the benign GYN surgery division. From there, brought it on to the chair, talked about it within the institute. We have the department, we call it the Women's Health Institute. From there, then we approached the surgical committee, which is a much broader committee formed by different the surgeons from different specialties. It's just like when you need to change the suture or bring in a new device, you need to present it to the committee. Of course, this was a much bigger discussion, arming myself with my PowerPoints of all of the evidence that is available, the impact to our patients because of the inability to have a power morcellator system involved. And then from there, training my group of champions, getting them very well equipped with using the new FDA-approved containment system, and now trialing it. So that's the process that we are in.
Dr. Barter, what about taking that tactic of also legal risk reduction to your hospital and working that avenue with your hospital?
We have to understand it from the administrator's standpoint. They don't want a big black eye. New York Times says patient dies from risky procedure, and so that's important. That's intel. You need to understand that's their perspective. Your hospital board, your CEO, your management people. That's really now what they're looking to avoid. Be able to understand what their arguments are going to be against you, and then logically present data, information that this is actually going to be a benefit.
And maybe Dr. Brown will have you kind of bring it all together with the value analysis idea. But there's also materials management, and sometimes we overlook this, but these are the boots on the ground. This is the person who has a budget and actually has to try and stay within a budget to stock the OR. So they have all kinds of restrictions that are placed on them. They're budgetary restrictions, and then there's contractual restrictions. They may have global contracting that they have certain numbers that they have to reach of certain equipment to generate actually cost savings, depending on the contracting. So also keep in mind that the materials management people, that things just don't appear in your operating room, that there's a process that has to be followed, and they're often very easy. They're a good link to keep in mind in the chain, because those are the people that you actually are probably dealing with. You don't actually know it in your operating room. And so having a good relationship with them, they can actually start you off to get you to, if you don't know who that next level up to speak to as you start to continue to advocate for the patient. Start with what you know, the boots on the ground if you don't, and then that will direct you into the other directions of the administrative piece, because we know how to maneuver in the clinical piece. And we can, as Dr. Barter mentioned, we can tell our hospital administration that we're going to do what we can to reduce the legal risk clinically by doing a better preoperative screening, by doing a better informed consent, and by doing using FDA-cleared devices for these procedures. So, Dr. Brown, can you talk a little bit about value analysis?
Sure. I mean, I think that you totally set the stage for that. You know, it all boils down to that equation of value equals quality over cost. So if we can improve the quality and decrease the cost, everybody wins. And I think the data that we have out there now really supports both of those concepts. We know that if we can keep women out of the hospital and avoid that laparotomy and that inpatient stay, that the quality of their care will improve, and we know that the cost will go down. And I think that this is a strategy to achieve that. And we're gathering the data, putting that together, and giving that to all of the players that you've heard, the hospital administrators. That boils down to materials and management, the OR committee, even the QI team, and legal. All of those different divisions of your administration need to look at quality, and they need to look at cost in order to get the value, because that's what every hospital is judged on these days. And I think that this system moves toward that.
Okay, with that said, I'd like to thank you for attending. We very much appreciate you having breakfast with us here this morning. I want to thank the Olympus staff and the technical team for putting this together. And thank you, and enjoy the rest of your meeting.
Thank you.